58-year-old male patient from Canada who was admitted to the hospital with signs of right heart failure with preserved ejection fraction. Due to the discordance between the QRS voltage in the electrocardiogram and the thickness of the left ventricular wall, by echocardiography, cardiac amyloidosis was considered as a possible etiology of cardiomyopathy. Subsequently, a pyrophosphate scintigraphy or PYP and salivary gland biopsy were performed, and this was compatible with transthyretin cardiac amyloidosis. Once the treatment of fluid overload had been optimized, target therapy with tafamidis was started. Now, the patient is currently stable under follow-up by the heart failure department, and our goal of this presentation is to highlight the diagnostic evaluation and clinical implication of cardiac amyloidosis. As an introduction, we can say that amyloidosis is a disease resulting from the accumulation of amyloid protein fibers in the extracellular space of one or more organs. But there are more than 30 precursor proteins with an unstable tertiary structure that can be fold, aggregate, and deposit. Specifically, cardiac amyloidosis is a type of restrictive cardiomyopathy in which the infiltration of amyloid fibers into the myocardial tissue results in progressive ventricular stiffness, wall thickening, and diastolic dysfunction due to this restrictive physiology, typically manifesting as a heart failure with preserved ejection fraction. But when the disease is advanced, we're going to see systolic dysfunction. The big problem is that cardiac amyloidosis can clinically simulate other cardiovascular disease, and the prevalence and incidence are uncertain. Talking about the classification of this disease, the molecular structure of amyloid protein is highly varied and gives rise to different types of cardiac amyloidosis, but we have to know that more than 95% are caused by ATTR amyloidosis or transthyretin and light chain amyloidosis. There are 4 types of amyloidosis with greater cardiac involvement, and these are: the first one, the most common, amyloidosis due to transthyretin deposition, known as TTR, and we have 2 types. One is acquired, or known as wild type, and the other one is genetic or mutant. The second one is systemic amyloidosis due to immunoglobulin light change, and the last one is amyloidosis due to secondary amyloid or AA. Talking about the transthyretin amyloidosis, this is caused by the deposition of transthyretin or TTR, that is a protein synthesized by the liver, which has a stable tetrameric structure and whose function is the transport of thyroid hormones and retinol. TTR can be dissociated into monomers or oligomers and then deposited as amyloid fibrils, and this can be in a natural way, known as wild type, or genetically known as mutant. The number of patients diagnosed with this disease has increased over the years, and it has been considered that it might be more prevalent than light chain amyloidosis. And according to different studies, TTR deposits have been identified in 25% of autopsies in patients older than 80 years old, and using non-invasive imaging methods, ATTR is estimated to be to represent the 13% of patients with heart failure with preserved ejection fraction, and 16% of those undergoing TAVI, the transcutaneous aortic valve replacement, in patients with low flow and low gradient aortic stenosis, known as paradoxical when they have a preserved ejection fraction. If the instability of this protein structure of the TTR is because of a genetic mutation, a cardiac or neurological condition will result. So we will known as ATTR hereditary or mutant, but we have to know that it's a very rare disease with a prevalence of less than 1 per 100,000 in the population. Currently, there are more than 120 mutations that can cause ATTR, and the most frequent mutation worldwide is the BAL30MET, which is endemic in Portugal, Sweden, Japan, Brazil, and Spain. This mutation can cause an ascending and symmetric sensory motor polyneuropathy with dysautonomia, and in 43% of the cases, cardiac involvement. Talking about the light chain amyloidosis, this is caused by a deposition of immunoglobulin light chain as a consequence of a plasma cells dyscrasia. The reported incidence is currently 1 in 100,000 people, being more frequent in people over 40 years old, compromising the liver, the lungs, the kidneys, the spleen, and the autonomic and peripheral nervous system. Cardiac involvement, which occurs in 50 to 70% of the cases, is considered to have a poor prognostic marker because light chains have a greater cardiotoxicity than TTR and consequently a lower response to the treatment. It is important to make a difference between the ATTR and the light chain amyloidosis because they have different clinical courses. For example, the ATTR has a slowly progressive development and is more common in older patients and predominantly with being males. And the light chain amyloidosis generally has a rapidly progressive course presenting at younger ages with less male predominance. Talking about the diagnosis, we should suspect cardiac amyloidosis when the patient presents, for example, symptoms and signs of heart failure with preserved ejection fraction. For example, right heart failure with edema, hepatic congestion, and ascites, and explain increase in the left ventricular wall thickness more than 12 millimeters and one or more red flags clinical manifestations. So we must perform the screening about this disease when we have a left ventricular wall thickness more than 12 millimeters and one red flags or clinical scenario. But we have to know that ATTR, for example, and light chain amyloidosis, they have a constellation of red flags that can be involved in the cardiovascular system, the neurological system, the autonomic. They can cause nephropathy, ocular symptoms, and also the musculoskeletal. For example, the neurological manifestation, the most frequent are dementia, headaches, ataxia, seizures, spinal stenosis. Then, for example, the ocular manifestation can be glaucoma, vitreous opacification, periorbital hematoma. Then the renal manifestations such as proteinuria or kidney failure, macroglossia. Also, they can produce cardiovascular manifestations such as arrhythmias, disorders at the conduction system, ventricular hypertrophy with low voltage, and aortic stenosis with low flow, low gradients in patients with preserved ejection fraction, known as paradoxical. Then the musculoskeletal manifestations such as bilateral carpal tunnel syndrome, the biceps tendon rupture known as Popeye sign, and rotator cuff tear. The sensory motor and autonomic manifestations such as neuropathic pain, muscular weakness, orthostatic hypotension, sexual dysfunction. And talking about the complementary test, the first one and the most common is the electrocardiogram, and we can find the low voltage, but we have to know that the absence does not rule it out in this disease. We can define the low voltage when in the frontal plane we have less than 5 millimeters, and in the horizontal we have less than 8 millimeters. Another thing that we can find at the electrocardiography is, for example, the presence of pseudoinfarction pattern, as we can see in this electrocardiogram in the right precordial leads. Also, we can find left atrial enlargement, and also we can find atrioventricular conduction disorders. For example, in this electrocardiogram, we can see the first degree block with left anterior hemiblock. So we can see that the presence of these clinical manifestations can increase the diagnostic suspicions, but their absence will not rule it out. About the laboratory, we can see that the patients will have the NT-proBNP persistently elevated with a low level of troponin, and we have to order the monoclonal protein screening test, and if we have 1 out of 3 positive, we must do the referral to the hematologist. Talking about the echocardiography, we will see bilateral dilatation. We can see also the granular-looking myocardium and the paradoxical aortic stenosis. But the most important thing will be the strain alteration with preserved apical segments known as the sign called cherry on top. Talking about the cardiac MRI, we will see the diffuse transmural late enhancement with T1 mapping increased by myocardial amyloid infiltration and an extracellular volume increase. So with the clinical and echocardiographical or MRI suspicions, the next step will be to request a pyrophosphate scintigraphy. And we have to note that the protein TTR has a high calcium content and therefore affinity for this tracer, and the light chain amyloidosis generally does not has affinity. So it now exists the Perugini score with 4 grades: number 0 without uptake, number 1 or grade 1 with mild uptake but less than the bone, number 2 greater than the bone but it's still visible, and number 3 a large uptake without the visibility of the bone. This is, for example, a patient with a grade number 3. Also, combining the pyrophosphate scintigraphy with this CT scan or SPECT, this will allow us to locate the activity of the myocardial uptake. So, if we have signs of cardiac amyloidosis by echo or MRI with elevated biomarkers and a grade 2 or 3 with a PYP, and also we have the exclusion of a monoclonal protein that could cause light chain amyloidosis, this will confer a positive predictive value of 100% for the diagnosis of ATTR. The biopsy in these cases is not required, and genetic testing must be done to distinguish an hereditary variant from a wild one. And when light chain amyloidosis is suspected, for example, when a PYP is grade 0 or 1 with light chains present in serum or urine, a biopsy of the bone marrow or other tissues, for example, abdominal fat or salivary gland biopsy, is indicated. And the microscopic examination will show a green color apple by Congo red staining. So this is the diagnostic algorithm when we have the signs and symptoms of heart failure with an electrocardiogram with the presence of the suspicion of cardiac amyloidosis, plus the echo or the MRI. We will have to make the pyrophosphate scintigraphy or PYP plus the hematological test. About the prognosis, the Mayo Clinic established a stratification system with the NT-proBNP, troponin T, and the free light change, and the presence of a grade 3 or grade 4 estimates a survival of 14 and 5.8 months, respectively. Our experience in Canada, we made a study, and we made a quality improvement project, and the objective was to determine the prevalence of the ATTR in Ontario, and patients with heart failure. We had patients with heart failure with preserved ejection fraction, plus unexplained left ventricular hypertrophy, and at least 1 red flag clinical manifestation, and the prevalence was defined by screening with the PYP. The most frequent red flags were proteinuria, electrocardiographic pattern of pseudoinfarction, and low voltage. And we also saw that patient with the PYP positive has more increase of neuropathy and carpal tunnel. The most important find was that the presence of 2 or more red flags could increase the diagnostic probability, and one of the most famous review about this This theme was published by Esedin et al., and they saw that a 6.3 global prevalence of cardiac amyloidosis in patients with heart failure with preserved ejection fraction, with left ventricular hypertrophy, and patients were screened with PYP. In this trial, we saw that we had 68% of cardiac amyloidosis ATTR when a clinical red flag was added to the trial. So talking about the treatment in patients with heart failure, the goal is to maintain the hypovolemia with fluid restriction and diuretics. And we have to know that there is no evidence with beta blockers, neprilysin inhibitors, angiotensin or aldosterone receptor or digoxin. On the contrary, they can produce hypotension due to autonomic neuropathy. When the patient has atrial fibrillation, we have to know that there is a high risk of a stroke or pulmonary embolism, so the patient must be on anticoagulation. But if the patient is in sinus rhythm, it is uncertain. The efficacy of the ICD in primary prevention is still unclear, and the tafamidis is the only drug indicated to reduce mortality and cardiovascular hospitalization in patients with ATTR or wild-type ATTR in class functional number 1 or number 2 with 80 milligrams daily. This drug can stabilize the TTR tetramer and reduce the TTR formation, and now it has a 1B recommendation, class 1B. So this was published in the New England Journal of Medicine. Talking about the light chain amyloidosis treatment, the patients are not suitable candidates for heart transplantation, except when they are receiving a stem cell transplantation or high dose of chemotherapy. And in patients with wild ATTR and patients that has only heart disease, they are good candidates for heart transplantation. However, they are usually diagnosed in people over 70 years of age, and they are excluded. And in patients with HTTR, these patients are young and may be candidates for heart and liver transplantation if amyloid neuropathy is absent or mild. Now, there are several trials. They are trying to find results in this type of disease. For example, the gene silencers, such as patisiran or inotersen, and deposit removers, such as doxycycline and epigallocatechin. So, as conclusion, we can say that cardiac amyloidosis is being diagnosed with increasing frequency. Recognizing the red flags is the first step towards a definitive diagnosis. The use of non-invasive techniques such as the PYP, the echo, the MRI, and the light chain amyloidosis in blood and urine allow early identification and treatment. Tafamidis is the only indicated treatment regardless of its low availability in the world. Thank you very much.
That was a wonderful presentation by Dr. Mariano Napoli, Llobera Health Sciences, North Hospital, Canada. Thank you, Dr. Mariano. We want to know if there are reactions or questions.